None of the faculty assisting with this session nor any family members have any conflict of interest associated with this presentation. However, we, Mike Patrizzi, Stephen Cole, and Jacob Miller, have published a book, a Sideline pocket guide, and app for the SMART Sideline Management Assessment Response Technique programs. These educational tools contain over 100 QR codes of videos, including many of the dislocation reduction techniques utilized during this workshop.
There are several complications that require urgent action when dealing with dislocations. First of all, hemorrhaging, especially when we are dealing with an associated pelvis or femur fractures. Open fractures, it's important that we immobilize and transport those patients as quickly as possible. Patients with arterial injuries, it's important that we assess distal pulse. If that's absent, we must attempt dislocation. There is much to be gained by attempting a reduction and little to be lost. Once you've attempted and made your reduction, you reassess the pulse, document, and transport. When you're dealing with nerve injuries, you always want to make sure you're assessing distal sensation and movement. Keep in mind that especially with lower extremity dislocations, compartment syndrome can develop. This generally develops later after the reduction, and that's why repeat assessments are so critical. This is a list of the various reduction techniques we will review during this session. Each is in an order as to how you would approach the patient on the field, and then progressing to if you had to move them to the sideline or inside to a treatment room. It's important during each of these techniques that you work to, first of all, have proper patient positioning. You properly position your hands to execute the reduction technique and understand the appropriate line of pull to execute each technique. We have videos illustrating most of these techniques, and it will be beneficial if you have a family member or partner with which to utilize as a model during the presentation. A couple of questions that we need to ask about acute management of dislocations. You need to decide, do you reduce prior to transportation or after diagnostic testing? How do you document and verify the extent of the injury? If you have a dislocated joint and you reduce it, how do you document and verify for follow-up that the joint was indeed dislocated? What assistance, expertise, and resources are available to you, not only on site during the athletic competition, but also from transportation and follow-up care? All of these things, all of these questions, you need to be asking in coordination within your local setting and the resources that you have in your local setting. So, why prompt reduction as opposed to why we would wait? First of all, prompt reduction, there is moderate evidence to support that it does improve patient comfort, improves joint integrity, and the follow-up functional prognosis for the patient. There's a higher relocation success rate with earlier reduction. There's decreased cost and psychological trauma to the patient with prompt early reduction. However, return to play faster in itself is not sufficient rationale to warrant why you would do prompt reductions of a joint dislocation. So then why should we wait? And we mobilize and refer. First of all, if we feel that a field reduction is contraindicated, such as with signs of a fracture. The legal liability. What are the guidelines for your institution and organization? They may have said you do not attempt joint reductions, and thus they want those managed at the emergency care facility, which would transfer that liability risk to that group. You would want to wait if you think there's a low chance of a successful field reduction. You don't have the proper equipment or support there, or maybe you have a highly agitated and excited athlete. You may want to just immobilize and refer that injury. And then if there's a high probability for poor patient outcomes, these were outlined in the NATA position statement. Pediatric patients under the age of 18 or senior patients over the age of 55, you should not consider joint reductions. There are always circumstances that we will talk about later that may override that. Diabetic patients may have poor outcomes, as well as patients with seizure disorders. So what are some of the issues with dislocation management? First of all, several require urgent reduction on the field. The knee, the hip, the elbow, and ankle. And these are generally associated with fractures and or neurovascular injury, and the reductions can be complicated. Then there's the rapid sideline reduction. Shoulder, patella, finger. Shoulder making up nearly 55% of all high school injuries. Patella, 16% of high school dislocations, and finger, 17% of high school dislocations. Reduction of these are relatively low risk and very simple approaches. So let's review the general reduction procedures. Starts with the patient presents with a joint dislocation. You assess for signs on the field or the sideline that a reduction is contraindicated. You assess and document their neurovascular integrity. You consider pre-intervention imaging and/or pain management. You document the patient's consent to perform a reduction. This should be witnessed and confirmed verbally. So it's not having the injured athlete sign a form on the field. It's having another person there with you. It may be the coach. And you have them witness that you have gotten the patient consent to perform the reduction. You have them confirm that verbal consent, and this is where in the post-reduction documentation you will note who that person was and how that occurred. With that patient consent, you select and perform the appropriate reduction technique. After you have successfully reduced the joint, you reassess the patient, assess and document their neurovascular integrity post-reduction. You apply the appropriate post-reduction care, which is immobilization of the injured joint and referral for radiological evaluation. Keep in mind, all first-time dislocations should be referred for X-ray. Imaging of repeat dislocations really depends on the clinical findings you have and how that's dictated in your standing orders.
Once you have performed the appropriate reduction technique and immobilized the injured area, it is important for you to check and document the facts. Function of the injured area: arterial blood supply, capillary refill, temperature compared to the uninvolved side, and sensation.
So let's discuss some pearls relevant to dislocation management. Most dislocations will feel better with traction. Slow, steady, inline traction will reduce many dislocations and realign many fractures. It is safe to attempt once, not multiple times, a reduction technique, even for an inexperienced clinician. As the patient will be saying to you, just pull on it. Keep in mind that most dislocations do not swell, at least initially, where fractures will, but there are always exceptions. The research has shown that neurovascular injuries occur at the time of the dislocation, not as a result of the reduction attempts. But that's why it's important that you document your pre-reduction and your post-reduction neurovascular status. Suspicion of a fracture should delay attempts at a reduction. Most isolated dislocations do not have significant swelling early on. If you have a joint with a lot of swelling, you should suspect a fracture and not attempt a relocation. Keep in mind that treatment for a pulseless dislocated joint is to relocate that joint and reestablish normal neurovascular status. So let's talk about the approach in dislocation management. First of all, it's critical. You must know your anatomy. You must have a solid anatomical foundation before you attempt any type of joint reduction. You've got to be able to assess the difference between, is the joint swollen or dislocated. You need to be able to check the neurovascular status of the extremity and document that. It's not because you're going to do harm, but you need to be able to document what the pre-reduction status is compared to the post-reduction status and continue to monitor that throughout transportation of that athlete to the care facility. Most reduction techniques involved inline longitudinal traction. There are many techniques that can be used, not just what we describe here. And it's really going to come down to your experience level, your comfort level, and understand that if one doesn't work, you need to try another one. Keep in mind, do not delay transportation or activation of EMS for high-risk dislocations, such as the tibial-femoral dislocation of the knee or a hip dislocation. Now, that doesn't mean you don't try a reduction technique. It means that you don't delay transportation of those injuries with multiple attempts. Motor and sensory evaluation of the lower extremity. We will be testing for dullness or the absence of sensation. Comparison of sharp to dull discrimination, You can focus on ankle and toe movements, and you should always compare bilaterally. The illustration on this slide shows the sensory or dermatome distributions of the various nerves of the lower extremity that you would want to evaluate. For vascular assessment, we will be assessing the following arteries of the lower extremity: the femoral artery, the popliteal artery, the posterior tibial artery, and the dorsalis pedis artery, as you will see from the diagram where the various pulse points are. For the femoral artery, the pulse point is in the hip region along the inguinal area. The popliteal artery is in the posterior aspect of the knee in the posterior popliteal space. The posterior tibial artery pulse point is at the medial aspect of the ankle behind the medial malleoli, and the dorsalis pedis pulse is on the top of the foot in the region between the first and second metatarsals. So let's talk about hip dislocations. These are a medical emergency, and early reduction within the first 6 hours is critical for reduced morbidity and to help prevent the onset of avascular necrosis of the femoral head. In sports, most hip dislocations will occur posteriorly, and they will present with the patient's leg on the infected side, internally rotated and flexed towards the midline, as you see in the diagram on this slide, as opposed to a hip fracture, which generally presents with an external rotation and shortening of the leg, as you see in the illustration on this side. The X-ray gives you an appreciation of the extent of the dislocation of the hip. Keep in mind that concerns about an acetabular fracture should not deter you from attempting to relocate and reduce a dislocation of the hip. First hip reduction technique we will talk about is the Alice maneuver. As you will see from the diagrams, there's really 3 phases to this, and it takes 2 individuals to accomplish. As you see in the first diagram A, the one clinician will grasp at the knee with it flexed at 90 degrees and provide an anterior directed traction. At the same time, another clinician will provide counter pressure and at the hip and provide gentle internal external rotation at the hip. Then the other practitioner, while providing that anterior directed traction, they will then adduct the hip while continuing with the inline traction. This is very easy to try with the patient still down on the ground on the field. Another hip reduction technique is the Whistler method, which can be performed by just one healthcare provider. This occurs again with the patient in a supine position. Unaffected knee is bent to 90 degrees. The affected hip is flexed to 90 degrees. The practitioner places their arm on the unaffected knee with their arm under the affected leg. This is illustrated in the diagram on this slide. And then with the other hand on the lower leg of the affected leg, they provide downward traction to help relocate the hip. Similar to the Whistler method is the Captain Morgan. In this one, though, we have stabilized the patient's hip by either strapping their hip down or having another assistant hold the hip in place. The clinician places their knee under the lower leg of the patient's affected leg, and then with their arm provides downward pressure on the lower leg, which then will help reduce the hip. This video will illustrate the Captain Morgan method. You see where the practitioner has their leg up on the patient bed, their knee under their affected leg, and they have their arm on their lower leg while the assistant is providing counter traction at the hip. And you'll see while the assistant is pressing down on the hip, the clinician will provide downward force on the lower leg, and you'll see this pop back into place right there. For a hip dislocation, our pre and post reduction assessment of sensory and motor focuses on the sciatic nerve and the peroneal nerve. For the sciatic nerve, we would assess the motor myotone function of knee flexion and extension. From a sensory standpoint, the dermatome area is the posterior thigh. For the peroneal nerve, our motor myotone functions would test dorsal flexion at the ankle and toe movements. Our sensory dermatome area is the lateral lower leg. For vascular assessment, we are concerned about the femoral artery, and we would check our femoral pulse in the hip region, as well as our dorsalis pedis pulse on the top of the foot and our posterior tibial pulse on the medial aspect of the ankle. Once again, it is time to practice these techniques. For the hip reduction techniques, you should practice the Alice, the Whistler, and the Captain Morgan. And again, the emphasis is on proper patient positioning as well as your proper hand placement and line of tension, and that of the role of your assistant, especially in the Alice and the Captain Morgan techniques. You should assess their vascular status, focusing on the femoral artery and checking the pulse points for the femoral pulse in the hip around the inguinal area, the posterior tibial pulse on the medial aspect of the foot, and the dorsalis pedis pulse on the top of the foot. Sensory and motor functions, we're looking at the sciatic nerve and the peroneal nerve. Again, with your patient partner, you're assessing knee flexion and extension and sensory distribution in the dermatome of the posterior thigh. For the peroneal nerve, you're looking at the motor functions of ankle dorsal flexion and toe movements, and sensory in the dermatome area on the lateral lower leg. This is a video of a mechanism of injury of a knee, a tibial femoral dislocation. This video is not for the faint of heart. You'll see how the athlete takes a direct blow to the anterior aspect of their thigh, which results in the dislocation of their knee.
A true knee dislocation occurs at the tibial-femoral joint. They can be either anterior or posterior, and they are classified by the position of the tibia in relationship to the femur. Surprisingly, roughly 40% of all knee dislocations are due to low energy mechanisms. You should be suspicious that a knee dislocation has occurred when the joint opens in both valgus and varus stress, indicating a multi-ligament injury. These injuries have a very high risk for vascular and nerve injury, and thus why it is critical that you document the injury after you have reduced it on site, transport that patient to an emergency care facility where they need to be admitted overnight, and monitor their vascular status with an arteriogram. Reduction is critical, as 80% will result in an amputation if not reduced in under 8 hours.
This video will demonstrate the reduction technique for a knee dislocation at the tibial femoral joint. It is a pretty straightforward and simple reduction. You can see you start with the patient's leg supported in flexion of about 45 to 90 degrees. As you will see, the provider will take one hand and put backward pressure on the femoral condyles while providing distal traction at the lower leg as they extend the leg. See how he's putting the pressure, pulls. Now keep in mind, this will be a very unstable joint, and so your post-reduction care is critical to immobilize the knee in your post-reduction care. With a knee dislocation, our pre- and post-reduction evaluation from a sensory and motor standpoint will focus on the tibial nerve and the peroneal nerve. The tibial nerve with the myotone motor function of ankle plantar flexion and ankle inversion. Sensory, the dermatome area is the posterior lower leg and the bottom of the foot. For the peroneal nerve, the myotone motor function again is dorsal flexion of the ankle and toe movements, with the sensory dermatome the lateral aspect of the lower leg. Vascular assessment will focus on the popliteal artery with assessment of the dorsalis pedis pulse on the top of the foot and the posterior tibial pulse on the medial aspect of the ankle.
The illustrations show the normal relationship of the patella and the femur, as well as what occurs when the patella dislocates. Most patella dislocations occur laterally, and you have an hemiarthrosis as well as pain over the medial retinaculum and a positive patellar apprehension test. You should suspect an osteochondral fracture of the patella or possibly the lateral femoral condyle, since over 51% of all patella dislocations result in some type of fracture. Chronic dislocators will often reduce spontaneously.
The reduction technique for a patella is very simple and straightforward. It involves extending the knee while applying gentle medial pressure to the patella to assist it in its relocation. Many times you can have this occur as the athlete is really rolling from their side to a supine position. Another aspect of post reduction care for a knee or patella dislocation is immobilization, and you would use a long leg splint. As you see here in the video, she has taken 2 of the flexible moldable splints. She has overlapped them under the foot and is now using an elastic wrap to attach them to the lower leg. As previously stated, especially with a true knee dislocation, it will be a very unstable joint, and it is critical that you get good post-reduction immobilization of that joint. You notice how the long leg splint goes all the way from the ankle up into the hip region. That is why it is always critical that you should have at least 2 of these full-length flexible medical splints in your emergency care bag. Again, this video will illustrate an ankle dislocation. This video is not for the faint of heart. As you will see right there, the ankle dislocation occurs. This is a very painful injury when it occurs. Ankle dislocations most often occur laterally, as illustrated in the previous video, and are almost always associated with several fractures involving the lateral and medial malleoli, as illustrated in the X-ray picture on this slide, pointed out by the orange arrows. It is important to assess the neurovascular status and reduce this ankle dislocation immediately if no pulse. As previously discussed with the posterior tibial artery running posterior to the medial malleoli, you could see where there could be some compromise of the neurovascular status. The reduction technique is really an external rotation with downward traction on the talus, and then a gentle internal rotation that creates a suction to help in the reduction. It's really what you're trying to do because of the fractures associated with this injury. You're really trying to realign structures so that you can reestablish neurovascular integrity to the area. This is an injury where you need to splint and transport immediately to an appropriate emergency care facility. This is a video showing the reduction of an ankle dislocation. This is not a video for the faint of heart. As you see, there is the dislocation. They are grasping the ankle, putting it into a degree of plantar flexion with some distal traction, and then puts the rotational force on the ankle to accomplish the reduction. As part of your pre and post reduction evaluation for an ankle dislocation, sensory and motor, again, we're focused on the tibial nerve and the peroneal nerve, with the motor myotome functions for the tibial nerve being plantar flexion and ankle inversion. The sensory distribution, the dermatome, is the posterior lower leg and the bottom of the foot. Peroneal nerve, the myotone motor function is ankle dorsiflexion with toe movements, and the sensory distribution dermatome is the lateral lower leg. Vascularly, once again, we are concerned about the popliteal artery and are assessing the dorsalis pedis pulse on the top of the foot and the posterior tibial pulse on the medial aspect of the ankle. As part of your post-reduction care, you would again apply in this case, a stirrup splint using the flexible moldable splint. As you see, she's molding it to conform to the lower leg. You might consider putting some padding around the ankle, around the malleoli, to accommodate for the associated fractures that will be there. And then you see how she is taking an elastic wrap, has the patient stabilize the splint and uses an elastic wrap to attach the splint to the lower leg, the stirrup splint. With any lower extremity injury, it is appropriate to consider placing the patient on crutches that would assist in their ambulation by relieving weight off the affected extremity. For fitting the crutches, it should be 1 inch to 1.5 inches below the armpits, with the patient standing straight up and the crutch tips 6 inches to the front and side. The hand grip height should allow for about a 20 to 30 degrees of elbow flexion, again with the patient standing straight up. One way to fit the person is to use the archer technique that I will talk about in the next slide, that can be used to fit crutches for a patient that is in a seated position. You should always instruct the patient to put their weight on the hand grips to avoid nerve and muscular injury by putting too much pressure on the shoulder pads. As far as ambulating with steps, you instruct the patient to first step up with the uninvolved, the good leg, going upstairs. When descending, going downstairs, they should step down with the injured or bad leg first. This is what we call the heaven and hell rule, where the good go up and the bad go down. These photos illustrate the archer method. You'll see with the patient in a seated position, you would have them grab the hand grip inside the crutch under the shoulder pad, and their forearm should fit right in there. If you do that, that will allow for the 20 to 30 degrees of elbow flexion. Relevant to the length, you have them extend their other arm, and the crutch tip should extend just beyond the length of their middle finger. Again, the shoulder pad should be 1 to 1.5 inches, roughly 2 finger widths down in the armpit, and the elbow should be at a 20 to 30 degrees of flexion, and this should occur with the crutches 6 inches in front and to the side. This is illustrated by the various arrows on the photographs here. So now it is time once again to practice these techniques with your patient partner. You should practice the reduction technique for the knee, the tibial femoral joint dislocation, emphasizing where your hand placement is on the femoral condyles while providing that distal traction to the lower leg. The patella dislocation reduction by placing your hand on the lateral aspect of the knee and providing medial pressure as you extend the knee. and the ankle dislocation, where you're providing that rotational force to realign the ankle and reestablish neurovascular integrity. From a vascular assessment, you should look at assessing for the popliteal artery by looking at the dorsalis pedis pulse on the top of the foot and the posterior tibial pulse on the medial aspect of the ankle. Motor and sensory were focused on the tibial nerve and the peroneal nerve. Tibial nerve, the motor functions, myotomes is plantar flexion and ankle inversion. With the sensory distribution, the dermatome is the posterior lower leg and the bottom of the foot. Peroneal nerve, you are looking at the motor functions of ankle dorsal flexion and toe movements, and sensory dermatome is the lateral lower leg. And then hopefully you have two flexible moldable splints where you could apply a long leg splint as well as a sugar tongue splint to the ankle, but you should attempt all of these techniques on your patient partner at this time. Let's talk about the documentation of care that you will provide. Here are several things that need to be considered in your documentation. First of all, what was your initial clinical findings? What was the joint and the degree and direction of the dislocation? What was your diagnosis with that dislocation? You need to document what your pre-reduction neurovascular status was, as well as motor function. You need to document your initial emergent treatment plan. What reduction techniques did you apply, and in what order? You need to document your patient consent. As we said, it will be verbal, and it needs to be witnessed and confirmed by a third party, and you need to document who that third party is and have them sign off on the documentation after the incident. You need to document what your follow-up clinical findings were. What was the post-reduction neurovascular and motor status of the patient? What was your transportation plan? How did you transport that person? How did you get them from the field to the sideline, from the sideline to the locker room, and/or from the sideline or locker room to the appropriate emergency care facility? And then what post-reduction radiological evaluation was performed? Let's discuss the consideration for standard operating procedures that should be in place prior to an incident where you would need to reduce a joint dislocation. First of all, you should have clearly outlined the circumstances with which a reduction technique would be attempted. First time versus recurrent dislocation. Absence of neurovascular integrity, presence of a fracture, and if we anticipate there will be a delay in transportation. Should also consider between various athletic events what will be the on-site resources that would be available to utilize during a reduction technique and post-reduction technique from a splinting and an immobilization standpoint. You should clearly outline the patient population with which you would attempt a joint reduction. Senior patients over the age of 55 and our pediatric patients under the age of 18, you should not attempt a relocation technique as a general rule. Patients with diabetes and seizure disorders can also have complications from certain reduction techniques. Keep in mind that the most commonly injured joints, the shoulder, the patella, the finger, can be readily reduced by a wide range of people, whereas the more emergent dislocations of the knee, elbow, hip, and ankle will require a more skilled clinician, and you should outline in your standard operating procedures who can attempt which reduction technique to which joints, and you should try to be as specific as possible in the technique that they would utilize. You should also outline in those standard operating procedures of the extent of the injury would dictate moving forward with a reduction technique, such as a knee dislocation, a tibial femoral dislocation, where you have no distal pulse or sensory distribution. You would need to move forward with some type of reduction technique immediately in that case. And then you should also document, and in your your standard operating procedures, what is the follow-up care that you're going to require once the reduction has occurred. So in review, these were the reduction techniques for the lower extremity that we reviewed during this presentation and will highlight during our live session.
Take-home points. You have to know your anatomy and be able to visualize the injury. It is important that you document neurovascular status pre and post dislocation reduction. You need to plan for situations when emergency reductions will be required, such as with the absence of neurovascular supply or where there will be delays in transportation. Select the appropriate reduction technique with regard to the equipment and support resources immediately available to you on site. Remember, it's critical to have the proper positioning of the patient and yourself for the reduction technique. Have appropriate post-reduction immobilization equipment on site.